Anyway, it's my great pleasure to introduce the Gaffney Lecture. The annual Gaffney Lecture was established in 1982 to honor our friend and esteemed colleague, Paul Gaffney. He died in May 1999 due to complications of heart surgery. His absence is still deeply felt on a daily basis by many here at Children's Hospital of Pittsburgh. I wish that our paths has crossed, but certainly his legacy has crossed my path. Paul Gaffney was known as a pediatrician's pediatrician since his days as a resident at Children's Hospital. He was then and continues to be a source of inspiration for all of us. Dr. Gaffney received his bachelor's and medical degrees at the University of Pittsburgh. He interned at St. Francis Hospital of Pittsburgh and then served as a resident here at Children's, and then was named chief resident. He then went on to do hematology, yay, at Children's Hospital of Michigan in Detroit. When Dr. Gaffney returned to Pittsburgh, he played an integral role in the development of the Children's Hospital of Pittsburgh and in the affairs of the University of Pittsburgh School of Medicine. By 1961, he was a full professor of pediatrics and on occasion served as the acting or interim chair of the Department of Pediatrics. During this time, he was the medical director of Children's Hospital, and he also served as the associate dean of admissions to the School of Medicine. And then from 1981 until 1990, he was the executive director of the School of Medicine's Alumni Foundation, or Association, I'm sorry. Dr. Gaffney received the Philip S. Hench Distinguished Award and was selected Man of the Year in the medicine by the Pittsburgh Academy of Medicine. He was also a 3-time winner of the Golden Apple Award for excellence as a teacher. In spite of all of his accomplishments, Paul Gaffney was first and foremost a clinician, a teacher, and a respected colleague for us all. In recognition of his service for so much time and his leadership, this lecture and visiting professorship have been established by his colleagues. Today, it's my great honor to introduce Dr. Sarah Alexander. Dr. Alexander received her BS at McGill University in Montreal, and then her MD at Harvard Medical School in Boston. She then trained as a pediatric resident at Boston Children's, followed by a Peds Hem/Onc fellowship at Dana-Farber. And she also received her master's degree at that time in Boston in 2000. So became a true Boston person. And then she was appointed instructor in pediatrics at Harvard, followed by appointment at the as assistant professor in pediatrics at Case Western in Cleveland, where she received many honors for teaching residents at the Rainbow Babies in Children's Hospital. Dr. Alexander was then recruited to Toronto in 2015, where she has now risen through the ranks to professor of pediatrics at the University of Toronto. Here, she continues to receive awards in the mentorship of fellows, including the Angela Punnett Mentorship Award for outstanding contributions to fellow professional development twice, and also the Richard Rowe Award for excellence in the delivery of clinical care in its broadest sense over a significant period of time. Boy, that sounds like an amazing award, and that was in 2019. Dr. Alexander has distinguished herself as a true leader in the field of pediatric leukemia lymphoma, especially non-Hodgkin lymphoma. Her research is focused on improving outcomes for children with non-Hodgkin lymphoma and on toxicities in oncology therapy with a focus on infectious outcomes and short and long-term complications of therapy for children with ALL, acute lymphoblastic leukemia, for those not in the field. Dr. Alexander has an extensive publication record in this field and is an active member and contributor to national societies such as the Children's Oncology Group, and is a mentor and colleague to many in the pediatric cancer field, including those in our own group. I'm very much looking forward to today's Grand Rounds, which is entitled Supportive Care in Oncology, More Than Just Being Nice. Thank you.
Good morning, and thank you for that very nice introduction. It's really my pleasure to be here and thank the Grand Rounds organizers and the Gaffney family, and especially to Erica Freeling, who I think was instrumental in this day. And I'm gotten to know her well through her role as the leader of the education committee at ASHFO, which she does an amazing job at. I also really want to thank Carla Clark and Christine Kiefer and Savannah Ryder, who maybe not here, but sort of exquisite organization and kind and thoughtful and just really nice. So the title is Supportive Care in Oncology, More Than Just Being Nice. We Canadians are known as being nice, but I want to convince you around the role of supportive care in oncology. We don't have any disclosures. I'm going to start with a case, and this is probably a case that may be very similar to someone who's sitting on your oncology ward right now. So the case is an 8-year-old child, an 8-year-old girl. She has come to your emergency room. She has about a week of fevers of unclear origin. She has some achiness in her back and in her legs. And in the evaluation in your emergency room, a CBC is done. Her CBC shows that she is anemic and thrombocytopenic, and she has a mildly elevated white count. And the hematology technologist and hematopathologist and then hematology fellow look at her smear and are suspicious that they're leukemic blasts. She's then admitted to your oncology ward, and in the next day, she has a bone marrow that makes the diagnosis of precursor B ALL. She has an evaluation of her spinal fluid that shows that she doesn't have any leukemia in her spinal fluid. There's a sophisticated genetics analysis done on that bone marrow sample that looks for prognosticators of either good or bad features of her leukemia, and she has neither good nor bad. She receives a month of induction therapy. At the end of that month, she has another bone marrow test that looks for the response of her leukemia to that initial therapy. And with that, from that information, you can pretty much define her package of therapy and what the therapy should be for the next several years and care after that. So that's sort of the leukemia doctors need to provide that initial care. What I argue is that the supportive care that is needed to take care of this child along the way is equally, if not more complicated, and got more parts of it than actually the complexities of thinking about the appropriate and optimal leukemia-directed regimen. So at the very beginning, she has a mildly elevated white count. She's at some sort of moderate, maybe low risk of tumor lysis, but you're going to pay attention to her electrolytes and to her creatinine. She has infectious risk. She's presented with fever. She may have presented with an occult infection. She absolutely will have infectious risks through the next 2 years of her therapy, both needing treatment and prevention. She has pain at presentation. She's already coming in with a limp and bone pain that needs to be thought about. She will have multiple painful and anxiety-producing procedures of bone marrows and LPs and other procedures along the way, and needing to think about how that is cared for. She presents anemic and thrombocytopenic, and before her bone marrow and LP can happen, someone needs to be discussing things with the blood bank and thinking about the appropriate transfusion medicine thresholds that she will require through her care. She's going to have periods on steroids where she's very hungry and eating unusually. She's going to have periods where she doesn't eat well at all, and thinking about nutritional support, and with families with lots of nutritional questions. She will have hundreds of blood tests and IV therapies, and she will need venous catheter support and figuring about what's the most appropriate to support that. And overlaying it all is her psychosocial support. So this is very disruptive to this child and to her parents and to her siblings. So coping, thinking about mood related to this experience and to the therapy, thinking about adherence to a complex regimen, including a complex regimen of oral therapy, caregiver burden and distress, financial distress and toxicity that comes with this therapy, and impacts on school and learning. So only to demonstrate that there's the leukemia part of it, which is interesting and is what we do. And there's the supportive care part of it, which involves many people beyond oncologists, but is a critical part to navigating someone through oncology care. So in 2024, and has been for a while, for the vast majority of kids diagnosed with cancer, there's really 3 goals. The first goal for almost everybody, there remains some exceptions where from the outset, there is not known curative therapy, and really from the outset, the goal is palliative therapy. But for the vast majority of kids from the outset, the goal is to try to cure this, make it go away, never come back. The secondary goal is to prevent the immediate and treat the immediate toxicities of therapy. And the third is to try to minimize what we're doing now on impacts on your health 20, 50, and maybe 100 years later. So the mainstay of today's discussion is the middle. And the middle matters because with current therapies, even as therapies become more sophisticated and more targeted, they remain toxic. There is a quote attributed to various people talking about that current conventional chemotherapy is a little bit analogous to, beating a dog with a stick to get rid of its fleas. That it really remains very nonspecific and with known associated toxicity. So managing those acute toxicities of therapy matters. I would also argue that managing the acute toxicities matters for the first and the third as well. If you have significant enough acute toxicity, that's going to impede your ability to deliver your effective curative therapy. If you have a terrible fungal infection and bone marrow transplant as part of your care, you may not be able to receive that component of your life-saving therapy. In addition, many of the immediate toxicities on therapy are short-lived and resolve and do not persist later in life, but some of them do. And so, for example, if you have a hemorrhagic stroke as a complication of your initial presentation of your leukemia, that's an immediate toxicity that may follow you through your life. So the immediate toxicities matter because there's a crumminess of therapy that you want to support people through. They also matter because they can impact how well you can deliver your cancer therapy and how well you may be when you're 50 years later. So I'm going to take a short segue into history. And this is a little bit Boston driven. Boston wasn't the only game in town, but I'm going to give you the Boston version of the history, which was, this is 77 years ago now. So in 1947, this is a quote from Sidney Farber that described the usual treatment for acute leukemia consists of verification of the diagnosis, after which the patient is discharged because there's no specific therapy available. Death usually occurs within weeks or months from massive hemorrhage, infection, or widespread involvement in the organs. A year later, so now in 1948 is the first publication that describes temporary remissions in children with acute leukemia with aminopterin, which is a folate antagonist similar to methotrexate, which we use now. So the evolution in the 1950s was really then late 40s was the discussion of, the identification of individual agents, many of which we still use now, methotrexate, prednisone, vincristine. And the first kids actually cured of acute leukemia was with the idea and the strategy of putting these drugs together. So the idea of combination chemotherapy what allowed it not just to be transient remissions, but the ability to cure a small portion of kids. But it was messy and unpleasant in those early days. And again, these are quotes from people involved in the care. In the early days, children were given methotrexate in a typical leukemia where it was not only blood on the patients, but on their beds and on the walls and the windows. Hemorrhage was rampant. There was not sophisticated transfusion medicine at the time. What was challenging was the intensity of treatment. Blood counts didn't come up for weeks. In fact, many children ended up in the intensive care unit ventilated for pneumocystis pneumonia or with septic shock. And then maybe the one that's pervasive when you look at this historical literature, the yellow chemical dripping through the intravenous line was as ubiquitous in the cancer wards as the patients clutching their nauseations afterwards. So the early days without the known ability to give antiemetic therapy. So early on, it became very apparent that you're not going to be able to deliver combination chemotherapy with all the excitement that it might have had without early on also addressing supportive care. Fever neutropenia was identified initially in adults with AML, that fever in neutropenic adults receiving AML therapy was a harbinger of sepsis and death, and you needed to be one step ahead of it. PJP prophylaxis identified in other settings, but also in children with ALL needing to be prophylaxed. Blood banking became much more sophisticated in the ability to be able to, in a timely fashion, receive platelet transfusions. And early antiemetics were critical in patients saying, okay, I will continue to receive this noxious therapy. So now 20 years after the initial quote, so in 1966, also leaning on Dr. Farber, increasing survival has been achieved in several ways. The first is by the aid of supportive therapy, in which the cardinal feature is the conception of total care for any patient, including those for whom we have no curative treatment. The patient and his family have received medical and moral support of the quality and magnitude never before possible. So I don't think there's a suggestion that oncologists have the monopoly on good supportive care or holistic care or family-centered care, but I do think that it's baked deep into the soup of the recipe of good oncology care, that it includes a breadth of supportive care as you're delivering these therapies that continue to be toxic, that continue to be very burdensome to get people through. So with that as a segue, I'm going to actually talk about three specific different topics, not particularly related to each other, of areas of supportive care that I've worked on in the last while. And they're largely around patients with leukemia and lymphoma. I think there's similar topics in other aspects of pediatric oncology. The first area is the prevention of serious bacterial infections in children receiving intensive chemotherapy. And the background to this, so this is actually from a Dutch cohort. The Dutch took 1,700 patients followed as a cohort over 10 years. And they looked at the overall survival of this group of 1,700 kids. And they looked at the what happened for those who didn't survive, what was the cause of not surviving. And it really into two bins. You only got to be in two bins. You either died of progressive disease, you either died of progressive cancer, or you died to a bin of treatment-related mortality. So there's a little complication in just being two bins, but there's only two bins. But you can see for the top left hand is the whole cohort of 1,700 kids. And in that whole cohort, there's just under 80% overall survival. The yellow is kids who died of progressive disease, and the purple is kids who died of treatment-related mortality. Under the figure below that is solid tumors, where you can see the biggest problem, the biggest is yellow. So the survival is a little bit lower than the overall group, but most of the patients who are not surviving are dying of progressive disease. To the right of that is patients with brain tumors, where clearly yellow is the problem. But if you get to hematologic malignancies, it's about half and half. So if you look at the causes of death in that cohort of kids who died, half of it is yellow, death from progressive disease, and half of it is death from toxicity. And if you look at they describe then the patients that are in the purple, the patients who died of toxicity. And again, more than half of it is related to infection. And of those infections, it's almost all death from bacterial sepsis and deaths from invasive fungal infection. So it remains, this is a cohort that was up until 2010. So it's getting a little bit older, but it remains, I think, relevant to today and to the outcomes of patients of today. And so treatment-related mortality from bacterial sepsis is bad, but there's also a whole bunch of other ramifications from bacterial sepsis, including organ dysfunction, delays of therapy, delays in being able to deliver effective therapy, quality of life, hospital days, and costs. So other reasons to think it might be good to have it become less common. So not every patient receiving leukemia therapy is at high risk for serious bacterial infection, and there are clearly therapy-associated blocks of therapy that put patients at the highest risk. For patients with ALL, consistently that is induction. And if you look at the induction rates of treatment-related mortality, it is almost always all mainly driven by sepsis. There are other causes. There's multi-organ failure, unclear diagnosis. There are occasionally hemorrhagic deaths, but almost all of it is related to infection. And you can see that in these examples of induction regimens, so the first month of ALL therapy, there's variability in treatment-related mortality. Some of that is explainable by the intensity of therapy. Kids with relapse disease get a more intensive reinduction than kids with standard risk ALL. Some of that is demographic features. So it's very clear that teenagers do worse or have higher rates of toxicity than younger kids. So if you get an older cohort in a relapsed ALL or a high-risk ALL, there's more toxicity, and part of that is demographics and not treatment, not as a specific manifestation of more intense treatment. So what about sepsis? With the caveat that sepsis is a difficult endpoint in studies to capture and is defined differently, probably as differently in the ER and the ICU and in oncology and across oncology trials, sepsis is defined differently. But with that as a caveat, there is clearly consistent data across studies around episodes of sepsis per intensive block of chemotherapy. And you can pluck out certain blocks, intensive blocks of therapy for relapsed AML therapy, and consistently blocks of therapy for AML therapy where there are consistently high rates of what would be defined as sepsis. So we go back in time, in around 2009, 2010, there was a group put together to say, The adults actually have lots of data around prevention of serious bacterial infections in adult oncology patients. And it's actually part of their bread and butter of what they do. And in my center, the adults are on one side of the street and we're on one side of the street. And if you are 18 and an adult getting leukemia therapy, you're going to get prophylaxis. And if you're 17 at my center and you weren't going to, and there's something not quite right there. There were literally, by 2009, there were dozens of adult randomized trials of prophylaxis, no prophylaxis in various cohorts, in various risk groups of adult patients. And from that, what we took away was that the impact was most significant in those with the highest risk of infection. So using prophylaxis in areas of care where it was less, you were less likely to have a serious infection, had less impact, and maybe the balance of good and bad was less good. And that quinolone prophylaxis was the agent, at least in that time, that was the most effective. So also at that time, there were almost no pediatric data. There was a lot of concern around drug-associated toxicity with prophylaxis, and clearly, and there remains concern around emergence of resistance. There was theoretical concerns around prophylaxis and C. diff, and concerns around prophylaxis and fungal infection. So we undertook within the Children's Oncology Group, which is a clinical trials organization of 200 or so pediatric hospitals in the US, Canada, New Zealand, Australia. Pittsburgh is a core member of, to try to address this question in children receiving intensive therapy for acute leukemia or transplant. Does prophylaxis impact your risk of having bacteremia? We chose bacteremia as the endpoint because it's pretty easy to measure as opposed to a much more complicated endpoint of sepsis. We looked at fever, neutropenia, and severe infection, death from infection, days of antibiotic exposure, and then also really wanted to focus on safety. At the time, there remained a lot of concerns around quinolones in children and the Beagle arthropathy, and also tendinopathy in adults and tendon rupture in adults. Look at C. diff and look at invasive fungal infection, and try to, in the context of a limited time duration of exposure, look at impact on resistance. This study enrolled 624 patients. The reason there's twice as many transplant patients is that early on it was identified that the baseline rate of bacteremia in the transplant patients was lower than expected, and therefore to have the power to see a difference, we needed to enroll more patients. And the good thing was that the transplanters were the most enthusiastic enrollers, so that was not a barrier to moving it forward. And the punchline really was that in patients receiving intensive blocks of therapy for acute leukemia, in those who received levofloxacin and prophylaxis, there was less bacteremia than those who didn't. Notably, it's not zero. So it is not, there's work to be done for sure, but it cut the incidence by about half. In transplant, there was a trend towards a decrease, but not a significant, statistically significant decrease. If we looked at the secondary outcomes across all patients, so putting the patients with leukemia and transplant together, there was significantly less episodes of fever neutropenia in those who had prophylaxis. And there was significantly less C. diff positive tests. We also look at C. diff positive associated diarrhea, so a very strict definition of what was C. diff associated diarrhea, and there was a trend, but not a statistically. But if you looked at the tests that were positive, there's less C. diff in those who received levoprophylaxis, which was a little counterintuitive until we also looked at antibiotic exposure. And I think because those patients who received levoprophylaxis had less bacteremia and had less fever neutropenia, they also therefore got less treatment exposure. So they had less aminoglycosides, less cephalosporins, and less of the routine antibiotics administered for fever neutropenia. So they had quinolone exposure, but they had less of everything else, which at least the theoretical explanation for less C. diff was then that they were having actually less net broad antibacterial exposure. So the takeaways from this study was that in this group of patients receiving very intensive therapy, levofloxacin decreased rate of bacteremia, you're less likely to have fever neutropenia, you're less likely therefore to have treatment antibiotic exposure, C. diff positive tests were less common. And in the context of this short duration of this trial on this 600 patients, there was not I didn't show this data, but there's not a detectable difference when we looked at surveillance stool cultures. There was not a detectable change in patterns of resistance. There was also not, again, in the limit of 600 patients, there was no identified levofloxacin attributed musculoskeletal toxicity. So it was at least a signal of safety. So I think, at least in our local center, we've adopted the 2024 version is that they're in these intensive blocks, it decreases infections. There's not a strong signal for drug-associated toxicity. We do have some data in children, and there's probably less C. diff. Since this is done, therapy, at least for the kids with ALL, has changed, not really for the kids with AML. And this, I think the utility of prophylaxis will continue to need to be evaluated based on therapy evolving. That some of the blocks of nasty therapy that used to be given to patients with ALL are no longer the nasty blocks of therapy. And one of the worries around levofloxacin, at least in my own institution, is sort of creep into areas where potentially that balance of goods and bads and that pressure on resistance is less clear. So I think the data really is around the most intensive blocks associated with the highest risk of bacteremia, that there's a pretty, I think, reasonable sense that it's an effective tool. So we're going to move now to a second topic. And the second topic is looking really at the evolution of more specific, so smarter targeted therapies. Immunotherapies now for lymphoid malignancies are here to stay. I'm sure that on your ward today, there's someone who is receiving rituximab or blinatumomab or maybe inotuzumab. So in the field of leukemia, it has absolutely changed in the last 10 years, where immunotherapies are part of core excellent care in children with leukemia. Rituximab was the first out of the gate in this area. And so this was a study looking at the impact of rituximab on immune function. So in the adoption of any of these new therapies, there is a sense that immune therapies are smarter, they're targeted, but they also have toxicities, and understanding those toxicities, which are different than our conventional toxicities, I think is going to be a really important thing in the next decade going forward. So I mentioned some of these. These are the agents that are now in your clinics, in your clinical trials, but also in your clinics. So blinatumomab is a BiTE. It's this bispecific T-cell engager that now is, for the majority of kids with precursor BALL, considered a core part of their care. It has very different toxicities and burdens than conventional chemotherapy, but a predictable feature of treatment with blinatumomab is at least a transient period of hypogammaglobulinemia. Inotuzumab is primarily used currently on trial and sometimes not on trial for patients with relapsed ALL. CAR T-cell therapy is absolutely now commercially available, used for patients with relapsed ALL, will make you B-cell lymphopenic potentially for the rest of your life, and hypogam. And again, rituximab, first out of the gate, has predictable toxicities, is relatively safe to administer, but has some very predictable toxicities. So just to remind people of the lineage development of a B cell. So this is the development of a healthy B cell all the way to a plasma cell. And sitting on the surface of these developing cells is CD19, CD22, and CD20, really almost from the beginning to the end, not the fully mature cell and not obviously the stem cell. ALL is generated from the cells at the beginning of this path, and diffuse large B-cell, Burkitt's lymphoma, Burkitt's leukemia are developed from sort of the middle blue cells along that path. Just so this is not the focus of what we're going to talk about, but just because these are relatively new in our clinic. So in the middle of this picture is a B cell. It could also be a B acute lymphoblastic leukemia cell with the same markers on its surface, CD22 and CD19. Inotuzumab is this antibody drug conjugate that brings the payload of ozogamycin to the cell. And these BiTEs, or blinatumomab, brings the T cells in proximity to the healthy B cell, but also to the B lymphoblastic lymphoma cell to allow it to be killed. But first out of the gate was rituximab. So rituximab was the first monoclonal antibody approved by the FDA for therapeutic use in cancer. It's a naked monoclonal antibody. It's a CD20-directed monoclonal antibody. Similar to the prophylaxis study, rituximab had been used in adult lymphoma patients for more than a decade and became standard of care for adults with diffuse large B-cell lymphoma and with clinical trials in patients with Burkitt's lymphoma for a decade before we knew if it had meaning in the care of children with similar diseases. So in around 2011, it was a clinical trial also run through the Children's Oncology Group, but this time done in collaboration with the Ike NHL group in Europe, was a trial to try to figure out in pediatrics patients with diffuse large B-cell and Burkitt's, did adding rituximab to our more intensive pediatric regimen also have an impact on event-free and overall survival. This study or this slide demonstrates how we're complicated as pediatric oncologists and in our staging and grouping of patients. But in pediatrics, unique to pediatrics, we put patients with mature B-cell lymphoma, so Burkitt's and diffuse large B-cell together. We lump them together. The adults don't do that. They really keep them separate. We lump them together and we put them into groups. And the groups, like staging, is trying to identify patients really based on, in this, sites and bulk of disease that have a less good outcome. So the red square is around those patients that are called group B high or C, and those are the patients in the pre-rituximab era that had a less favorable event-free survival. So with intensive multi-agent chemotherapy, they had an event-free survival of 84 and 80%, unlike those with less disease that were already sitting in the high 90s. So these are the patients that were the target of the study. The study took these groups, stratified them into their risk group, and it was randomized, open label randomized intensive chemotherapy versus intensive chemotherapy plus 6 doses of rituximab. So pretty straightforward design. And the punchline from that study, not unexpected and similar to the adult data that had preceded it, was that in this group of patients with high risk mature B-cell lymphoma, the addition of rituximab significantly improved your event-free survival and got this group that was sitting in the sort of low mid 80s to the low mid 90s. So rituximab is now the standard of care for patients, at least with higher risk mature Burkitt's and diffuse large B-cell lymphoma. Built into this study was to try to understand the impact of adding rituximab. So if the idea is that it may be good because it's going to improve the event-free survival, what's the cost? What's the potential downside to the addition? We're intensifying therapy further by adding another agent. What's the downside of doing that? So this study was really a study of laboratory correlates of immune status. This is so it's really lab data as opposed to patient outcome data. The laboratory data was sort of clinical labs and not more sophisticated evaluations of immune system function than that, but really is IgG and IgM and CD19 and 20 count and your absolute lymphocyte count. So really basic labs that any clinical lab could measure. The studies were done at the time of diagnosis and then at the end of therapy and then a year later. And then the intent was yearly, if not normalized. It turns out that's a bad way to design a study because people looking back to the year prior to know if they were normalized, not when they're ordering their test, doesn't really work. So note for future design. We also measured whether or not patients received. So did people respond to these labs? If you were hypogam, did you receive or did you receive IVIG regardless of whether you were hypogam? There was very wishy-washy protocol recommendations. Sort of said, don't give immunoglobulin just for low level, give it if there's severe repeated infections. You should take that in consideration. You should talk to your national co-investigator to take the decision or follow your national guidelines. In the time, there were 0 national guidelines. So you could argue that that probably wasn't a particularly helpful line in the protocol for people. So what about the data? So at the end of therapy, in the patients, when you look at the patients who received intensive chemotherapy versus those who received intensive chemotherapy plus rituximab, at the end of therapy, those who received rituximab were more likely to be lymphopenic. They were almost all profoundly B-cell depleted, not surprisingly. So almost all of them had a B-cell count at the end of therapy of less than 100. And the majority were hypogam at the end of therapy, and more so in those who received the rituximab therapy. So not really surprising. But at a year later, the B cells had recovered. So there's no longer a significant difference between those who had or hadn't received rituximab a year after the end of therapy. But a year after the end of therapy, those who had received rituximab, there was still a higher proportion that remained hypogam a year later. The data after a year later gets a little skinny. There is some suggestion that there's a small portion of patients who remain hypogam to the last point of measurement, some of which is years later. Again, with the loose directions that were in the protocol, there was significantly more IVIG administered to those who had received rituximab. And when sites were asked for the attribution of why they gave the IVIG, the most common reason was just for low lab level, or low IgG level. But actually, when we looked at it, probably the most important prognosticator about who got IVIG was what country you lived in. So if you lived in Poland or Italy, you were pretty likely to get IVIG. And if you lived in Hungary and Spain, you never got IVIG, which I think is just, again, sort of a message of no one really knows what the right, so there's barriers, there's system barriers and insurance barriers and other things to giving it, but clearly there's a lack of sense of whether this is a meaningful thing to do. We attempted in the study so one of the things that we did do was there was a single case of a serious infection post-therapy, between post-therapy and a year post-therapy, in a patient who got rituximab, who was hypogam, who had a serious infection, was in the ICU, but as a single patient. There was an attempt to look at lower grade infections, but they're really difficult data to capture in this setting. So whether or not there's more sinopulmonary or outpatient type infections in those who are hypogam was not measured in this. So I think in the era where we are going to be delivering more and more therapies, so rituximab is now standard of care for patients with higher risk diffuse large lymphoma and Burkitt's. Blinatumomab is now standard of care for the majority of kids with ALL, with much less data on whether or not the length of time and the time period at risk, if at all, related to hypogam and blinatumomab. And none of this has addressed the potential impacts on vaccine preventable diseases. What does that look like? There's pretty limited data already. If you were a child with ALL at the end of therapy, what are your vaccine responses? Should you be vaccinated again? Who knows? In the era of everyone receiving immunotherapy, I would say it is a field waiting to be evaluated, though vaccine studies, I think, are hard and maybe hard, at least in the children's oncology group, to think about doing now. But there's a paucity of data, I think, to know what to do with IgG results, to do what to do with therapeutic replacement of IVIG. And there's a huge paucity of data around vaccine preventable diseases in the children who have been treated with immunotherapy and even in the ones who haven't. And then I'm going to switch gears one more time to a totally different field, not related to infection or immunotherapies, but a different area of supportive care, which is around thinking about the impacts of anesthesia, repeated episodes of anesthesia in kids with leukemia. And the brief background to that is that it has been known for a very long time that a substantial portion of children with ALL treated with contemporary therapy, even without cranial radiation, will have long-term neurocognitive impairments. So in the development of leukemia therapy, it was identification of individual agents, and then it was combination chemotherapy. The next major leap in curing kids with ALL was the realization that if you give drugs by mouth and IV, the CNS is a protected space, and you needed to give CNS-directed therapy. The initial CNS-directed therapy was craniospinal radiation, and that was relatively quickly identified to have really significant long-term impacts on risks of a secondary brain tumor, on devastating neurocognitive impacts, especially on very small people, and endocrinopathies related to radiation. So it was in the 80s, there were trials that compared cranial radiation to intensive intrathecal therapy. Intensive intrathecal therapy was just as effective and had less of these morbidities. So it remains in North America today. We use more intrathecal therapy than the Europeans do, but the average child receiving ALL therapy receives somewhere between 13 and 25 doses of intrathecal therapy during their ALL therapy. There are known risk factors for this neurocognitive impairment in survivors of ALL receiving contemporary therapy, no radiation, and that includes exposure to methotrexate, both systemic and intrathecal, includes demographic features, so younger age is a risk factor for worse outcomes. There's data now clearly around socioeconomic status as a risk factor. There's data that describes biologic sex, so girls having more effects, though that has, I think, gone back and forth a little bit and is less clear in the current era whether girls are actually more at risk than boys. But one factor that was being evaluated not in the oncology space for several decades before was whether exposure to anesthesia has what's the potential risk to that on young and childhood brains for neural development. And in this package of kids who receive multiple anesthetic episodes, is there a possibility that that's a risk factor? And if so, then that potentially is something that would be modifiable, not removable entirely, but potentially modifiable. This is a picture of the pamphlet that's given to the parents at my center, where there's a sort of happy looking child with hair on his head, and he's got a bunny and he's curled up and he's good. This is a picture from one of my patients who in the propofol era, right, that these remain distressing episodes of care, whether you get your propofol, you don't get your propofol, it's an impact when we've done now surveys of the components of care from parents. So this is proxy, this is the parents reporting. And the two features that have stood out in these recent surveys, one is that we don't recognize nausea enough. The second is that procedure days are distressing. And so even in the propofol era, I think that they remain distressing. The evolution of, intrathecal therapy became a mainstay in the 80s. This is abstracted from a editorial written by Dr. Shah, who described the historical evolution of the procedural sedation, so to speak. But in the 80s, it was really the sumo wrestler technique, where you would find the strongest willing clinic participant who could hold the patient, and you would hopefully have a very effective procedure doer who could be quick. But it wasn't clear that even if they were a very skilled proceduralist and a very strong sumo wrestler, right, the next time they came, they might be actually more anxious than the last time. In the 1990s became the relatively common use, largely administered by oncologists and nurses, of procedural sedation, mainly with Versed and fentanyl. I think there were goods and bads of this era as well. There was concerns around inconsistency and monitoring and as this optimal safety of sedation practices. And in the 2000s, if you look at survey data really across North America, that anesthesia units and propofol as the agent for these brief procedures became the standard and most commonly used regimen across the board. So the question raised is really, is that it? Are we good, or is there something that we should be thinking about as we go forward? So I'm not gonna, there's relatively extensive literature and now meta-analysis of the literature of the impacts of various anesthesia agents. A lot of them is around sevoflurane, but other agents on outcomes of children. A lot of this literature is single episodes of anesthesia, brief episodes. Some of this literature doesn't capture the actual anesthetic agent. Some of it uses limited neurocognitive batteries. There are several randomized trials where there were trials where for patients having hernia repair, where it was randomized between sevoflurane and local anesthesia. And there's a mix of results. So there are some of these studies, and I'm just putting up four. You could have put slides and slides and slides. Some of these studies did not detect an impact of anesthesia on subsequent neurocognitive outcomes, and some of them did. There's also preclinical data. So in mouse models and also in non-human primates, we're looking at basic biology and a plausible biologic sense of toxicity from a number of anesthetic agents. It's like I'm not moving forward anymore. There was enough that in the 2016, the FDA put a black box warning on anesthetic agents that says lengthy use of general anesthetic or sedation drugs, repeated or lengthy use in children younger than 3 or pregnant women may affect development of children's brains. And this black box warning has changed a little bit in its verbiage, but has essentially stayed there since then. So what does it mean for children with ALL? So the first real assessment of this was a study done at St. Jude's, published a couple of years ago. This is a study at St. Jude's where they took a cohort of patients treated. They'd had 212 kids who had been treated for acute lymphoblastic leukemia. They were an average of 7 years post-therapy, and they were in their survivorship cohort. And they looked at these patients and they did detailed neurocognitive, so neuropsychologists administered detailed neurocognitive assessments. And then they went backwards and collected all of their anesthesia exposure data. And they were able to capture that these patients had had a lot of anesthesia. So not surprising that the mean number of anesthetic episodes in this cohort of 212 kids who'd been treated for ALL, now 7 years later, was 26 or almost 27 episodes of anesthesia. And the cumulative time of anesthesia was almost 15 hours. So again, brief, multiple procedures. They did capture what the procedures were for, and unique to this population and probably unique to St. Jude's was that a significant contribution of anesthesia time in this cohort was research MRIs. So that's unique to their long-term survivorship cohort and actually their on-study survivorship cohort, different from other people. But the total number and the cumulative time was not surprising. When they look at this cohort of 212 patients, they're comparing their outcomes, their neurocognitive outcomes, to population norms. So in the way they are doing their testing, you'd expect that about 5% of the general population would be considered meeting the criteria for neurocognitive impairment. And in this cohort of 212 patients, it was 43% of the patients met the criteria for neurocognitive impairments. There's always also some question around those patients who show up for survivorship studies may not be exactly representative of all survivors. Are you more likely to show up in survivorship studies if you have a concern? Maybe. So this is a survivorship cohort, not a prospective cohort. They described the anesthesia per agent, and really the mainstay of their findings was that propofol, your cumulative propofol exposure was associated with a significantly increased risk of having neurocognitive impairment, and that there was also a dose response. So that those that had the highest amount of propofol exposure had an even higher risk of having a neurocognitive impairment. There was an association in their hands for cumulative time of anesthesia and risk of neurocognitive impairment, and there was an association in their hands between episodes of sevoflurane anesthesia exposure and neurocognitive impairments. So I think that study was provocative and made people pause and think, but it's unique and it's a single center and it's a survivorship study. So there was then work put together to say, can we replicate this? Can we understand this in a setting, in a multi-center study? In a uniformly treated cohort of patients. So the survivorship study takes patients that had standard risk ALL and high risk ALL and treated on various different St. Jude's related protocols, but can we take a uniformly treated group of patients where their therapeutic toxicities would be perceived to be similar, and really replicate what the St. Jude's team has done. So and also learning from what they done, really trying to focus on propofol as potentially the agent for which there was the most concern and the one that we use most commonly, and really also focus our primary aim on processing speed and reaction time, which seems to be the neurocognitive specific entity for which there's the most direct toxicity. The other change in this was to look a year after therapy. So in general, the perception is that neurocognitive impacts actually increase with time. And was there a sense that you could measure early on a signal of neurocognitive impacts a year post-therapy to really try to identify those kids for which you might want to intervene in a significant way? So the primary aim of this study in a multi-center cooperative group trial was to look at cumulative exposure of propofol and neurocognitive outcomes 1 year after the end of therapy. The neurocognitive assessments here were targeting the same neurocognitive constructs, but measured in a very different way. So these were measured with a computerized task called CogState, which is a performance-based task that has been used in children's oncology group trials to measure on therapy and post-therapy neurocognitive outcomes, and is a legitimate tool, but also is feasible in the cooperative settings where you don't have neuropsychologists at each center at each time point able to do these measurements. We also measured it using BRIEF, which is a parent report measure that looks at behavioral correlates to neurocognitive difficulties. We measured the anesthesia data amounts very similar to the St. Jude's. We took their CRF and made it our own. So we looked at the name, the dose, the duration, the indication for anesthesia, and the patient's weight for each episode from the time of diagnosis through 1 year post-therapy. And we then added up the cumulative exposures for each patient. The primary outcome of interest was reaction time and processing speed, and it was 1 year off therapy. And we attempted to account for the known demographic and treatment-related risk factors for neurocognitive outcomes. So the group of patients, this was done on the backbone of a high-risk ALL trial. So the youngest patients were not included, and this COG state was really only validated for 6 and up. So that also precluded the youngest high-risk patients. So this is a group of patients between 6 and 12 years old. There were 144 patients. They were drawn from 73 different children's oncology group sites. It was equal split of boys and girls, and race and ethnicity as captured routinely in the children's oncology group, with insurance status for good or for not, or for valid or not, to some degree valid, maybe some degree not, as a proxy for socioeconomic status. We captured leukemia risk groups because there's a slight difference in the number of intrathecals if you had high risk or very high risk ALL. There were 3 patients in this cohort who had CNS3 disease. Those 3 patients did receive cranial radiation. Those 3 patients who received cranial radiation did not receive anesthesia for their cranial radiation. And we looked at grade 3 and higher neurologic toxicities as another potential predictor. Uniquely, similar to the St. Jude's, the median number of anesthetic episodes is 27. So again, this is a cohort of patients who have had many, many, many anesthetized procedures. And one important takeaway was that almost 80% of the total propofol exposure was just for lumbar punctures and intrathecal therapy. So there's clearly other reasons. There's bone marrows and there's lines, ins and outs, and there's appendicitis and dental procedures and a few others. But the vast majority of the anesthesia exposure was for intrathecal therapy alone. Almost everybody received propofol during their care. Fentanyl was also quite common, and then there was a bevy of other exposures. One of the things that was in the study is there's a less ability to be reassured that some of the other agents don't have an impact because there's less events to be measured in this data set. About half of the patients received an episode of anesthesia that had fluorine, and the anesthesia time was a little bit less. The cumulative anesthesia time was 11 hours. I would say this was the most difficult data element to collect. Some of this data was collected in patients for which paper charting was what was used at the time. And we would have sort of shuttle sheets of paper anesthesia records on paper where the poor site CRA would say, I don't think I can really tell you when this started and when this stopped. So the measuring anesthesia time in this data set was probably the element that had the most potential variability. If we look at neurocognitive outcomes at this point, there was a baseline assessment done in the first 3 months of therapy. And already in the first 3 months of therapy, there's a difference between, so the green bars are the population norm, or the dark green bars, the population norms, the light green bars are the patients. Already a month or 3 months into therapy, there's a difference between patients and population norms. But if you look a year after therapy, and a year after therapy, you are now a well kid, you're not encumbered by receiving therapy, and at that point, there's a significant difference in the patients treated for leukemia and their neurocognitive outcomes as measured by COG state compared to the population norms. And if we look at the predictors related to anesthesia of risk of having a neurocognitive impairment, propofol was statistically associated with your risk of having an impairment in processing speed a year off therapy. And if we looked accounting for sex, race, ethnicity, socioeconomic status as measured by insurance, leukemia risk group, sex, that your baseline score predicts your subsequent score, and propofol exposure was clearly associated with your risk of neurocognitive impairment a year later. So what does what do we take away from that? So I think the sense is that this did replicate what was identified in St. Jude's in a different cohort at a different time point using slightly different measures of neurocognitive function. And I am not a propofol hater. I am a proceduralist, and it's awfully lovely when they're very still. But I think there are huge opportunities to think about ways, especially for lumbar punctures, for intrathecal therapy for kids with ALL, where we can think about, are there ways for some kids at some times where they can have just as good anxiety control and just as good comfort with different regimens. And for some that may just be MLUF, for some that may be midazolam. And that the ease of propofol may be a little bit too easy, and there may be ways where we should be thinking about doing other things and taking the time to strategize around doing other things. So I'll just end with the same 8-year-old. I'm going to give her a bit of a sad story. So she's treated with ALL with intensive supportive care. She does well, but unfortunately she has a relapse 2.5 years later. She's now 11. She's going to receive intensive induction therapy for her relapsed ALL. Then she's going to get some levofloxacin prophylaxis, and hopefully that will have her have less of a chance of having a serious bacterial infection during that first month of reinduction. She's now going to have not intensive blocks of therapy following induction, but she's going to have blinatumomab following her induction. It is really unknown whether we should be monitoring her immunoglobulin, whether if we find it's low, should we be replacing? But that is something in the next decade, or maybe less than that, that we need to find out and figure out. And she's had now 29 episodes of anesthesia in her initial therapy. She's 11. She is finding this all very distressing. Her way of coping to coming to clinic is with her mother. She goes and gets a chai latte on her way to clinic. If she could have her chai latte and come and get midazolam, she will find that that's going to be less distressing than coming without breakfast that day and needing to have her procedure. So now as an 11-year-old, that would be something that maybe she would want to talk about and think about if that's a different way to make some of the misery a little bit less. And with that, I just want to provide acknowledgement. So this is a slide from the levofloxacin study where we asked little patients to take pills. We did perirectal swabs to look at resistance. We took blood tests. We had for an antibiotic study, right? This is a study where it's an antibiotic or no antibiotic. The Children's Oncology Group consent was 29 pages long that we asked patients to sign. And if you read it deeply, the first serious toxicity noted on the consent was that it might cause your heart to stop beating. And despite that, I think for altruism and interest and academic interest, parents and kids sign up for these studies. So none of this would happen unless the community of oncologists was engaged and the community of parents and kids said, okay. I also want to acknowledge a whole bunch of people. So one of the joys of supportive care research is that on this list are neuropsychologists and anesthesiologists and infectious disease doctors and statisticians and nurses and not really immunologists, but that's what we need next, that it really is a bevy of great people. And with that, I will end.